We are very happy and grateful that Dr. Bliss is with us this morning. Dr. Andrea Bliss is a psychologist for the MAPS OCD clinic at the Alberta Children's Hospital and the founder and owner of Child Forward Centre. She specialises in the assessment and treatment of anxiety, obsessive compulsive disorder, and related disorders in children and youth. She's a clinical associate in the Department of Psychology at the University of Calgary and provides workshops, training, and supervisions for students and other professionals on the assessment and treatment of OCD within the family context. I hand it to you, Dr. Bliss.
Thank you, Julian. Let me just change my screen here. Great. Welcome, everyone. Thank you so much for coming this morning to talk about behavioral treatment for pediatric anxiety. As you can see in the overview there, I have some pretty ambitious goals for this morning. So I will try to keep pace and make sure that we have time to do some Q&A at the end. Behavioral treatment for anxiety is evidence-based care for anxiety treatment, and it's really rewarding work. This is work where we can see changes week to week. Families notice meaningful changes week to week, and it's really fun. So now that we're all excited, let's get into it. So just a little bit of context. Behavioral therapy, of course, is within the context of cognitive behavioral therapy. And I suppose in this case, we're looking at a small c and a big B in this treatment. And the goal here is really to show families that the way that they're responding to anxiety or anxious thoughts is getting in the way of them living their lives. And so we want everyone to see their role in this treatment and see how they can help, kids recognize anxiety and get them back to doing things that they should be doing by doing the opposite of what anxiety wants. If we look at, broader behavior therapy context, we want to have kids and youth doing the opposite of what anxiety wants, but with the skills to do that successfully. So for example, if you're asking a youth to face their social fears and approach a peer, and ask them a question, we want to make sure that they know how to do that in a successful way before we jump in. Today, we're actually going to be narrowing that definition down a little bit more and looking at exposure therapy. So I have a formal definition there. It's behavioral treatment approach designed to help the client to approach and engage with anxiety-provoking situations, items, or individuals that pose no more than everyday risk. Now, here's the kicker: without the use of coping skills. I'm going to be talking a lot about that today. There's often a lot of questions about that, so we will get there. This treatment is a science because it's evidence-based, but it's also an art. It is our chance to get creative and really create opportunities to help kids face their fears with our support and not doing it on their own. And so each client will present differently and have unique concerns. And so this is a chance to make a really individualized treatment approach that is patient-specific. What is our goal in exposure work? Well, very broadly speaking, and some language here that I would actually use with families, we want to help kids face their fears so that their world does not get small because of anxiety. Get them off the sidelines and into the game. We want to make sure that kids are making decisions for themselves. Anxiety is not making it for them. We want to make sure that kids are not missing those very important opportunities to grow, challenge themselves, and learn from situations. And essentially, it's to help kids get comfortable being uncomfortable. Really, nothing builds confidence more than doing something challenging, working through that anxiety and those uncomfortable feelings that come up with that, and seeing that you come out the other side and you're successful with that. I think if kids know that at a young age, they'll try out for that sports team, they will go for that job that they want down the road. So to me, this is a wonderful gift that we can give kids and families. Okay, so getting into some theory here, really the goal here is to face fears, but the specific goals and the rationale for this anxiety treatment has changed over time. So, I created a whole history lesson on the use of exposure therapy over time, which I actually found really fascinating to dig into. Perhaps lucky for you, I had to come to terms with just not having time to go through it all. So let me give you the briefest history lesson of all time. The goal in all of this, again, is facing fears. With systematic desensitization, the goal here was to move systematically up a hierarchy or a ladder from least to most anxiety-provoking situations. The emphasis here, the goal was to have clients be very relaxed when facing a fear. So relaxation strategies were heavily practiced. Along came flooding and implosive therapy, as the names imply. Clinicians and researchers, they really emphasize facing big fears right away and then preventing an escape or avoidance response. So the client faced their fear head on and they were in that situation until their anxiety came back down. Along came CBT manuals. These were typically multi-component, so they included cognitive restructuring, relaxation, and coping strategies. And often relaxation and coping strategies were used during exposure work. Later manuals actually took out the relaxation and the coping strategies, especially during exposure work. And it turns out that these manuals were just as effective as the ones that emphasized relaxation. So really started to highlight the very important role of exposure work and I guess essentially de-emphasize the role of relaxation strategies. So a big emphasis to this point in history was on habituation. We wanted clients to face their fear, see that anxiety comes up, but then it also goes back down. And that was really the aim, was to see that anxiety or habituation happened in session and between sessions. And that was, traditionally considered a key indicator that treatment is working and it's effective. Okay, so more recently, so actually a key article came out in 2008, another one in 2014. This emphasis on habituation was really criticized or called into question for a couple of reasons. One, those clients who showed this beautiful habituation curve in session or between sessions did not necessarily do well long term. Other clients who never seemed to see habituation actually did well long term. And so it highlighted that maybe habituation is not so important after all. The other thing it was criticized for was really conflicting messages about anxiety. So a lot of, these CBT manuals, for example, it starts with a lot of psychoeducation about anxiety, which is great. But to talk about this fight, flight, or freeze response, anxiety being a normal human experience, part of life, and playing an important role, actually. And then we get into exposure work, and the goal would be on controlling anxiety, reducing anxiety, which inherently sent a message that anxiety needs to be controlled or it's intolerable, and that our goal is to be anxiety-free. So with all those criticisms came inhibitory learning theory. And that's really the latest and greatest and what we're going to be talking about here today. So what is the aim of this exposure work? It's still to help our clients face their fears, but without the use of safety behaviors like relaxation strategies, so that the client really learns that anxiety does not have it right, that their feared outcome is not likely to happen or be as bad as they expect it to be, and that feelings of anxiety are safe and they're manageable, and they can handle it. So, in other words, it's about getting better at having anxiety, not making anxiety go away. The goal here is to do exposure work both in session and between sessions. I'm going to keep saying that this morning. And we do that by creating very, very planned opportunities to practice working through anxiety. Not on the fly as opportunities arise, but really creating those situations. And then we're, actually also creating very repeatable steps. So the child can see over and over again that they can do this and they can tolerate anxiety. While really structured and planned at the beginning, the end goal is really to adopt an exposure lifestyle and to, face that trigger head on, take that opportunity as it comes up, and for them to know that they can do that for themselves. Okay, those are the big aims. We also want to make sure that clients are learning as much as possible from this work. And what do they need to learn based on this theory? They need to know that their expectations for a situation are not founded. In other words, anxiety says this big bad thing is going to happen, but let's build up evidence that that is not true. More specifically, I have a few examples of some anxiety disorders there. So with social anxiety, the client needs to learn that negative evaluations and judgments from others are not as horrible as they think, that they can tolerate that. For someone who has panic attacks, they need to learn that those physical sensations are okay. They don't lead to physical or mental catastrophe. I did throw OCD in there. And what do they need to learn? That intrusive thoughts are safe, they're manageable, they're not predictors of danger. And in other words, a thought is just a thought. For generalized anxiety, they need to learn that the uncertainty about things happening is tolerable, that uncertainty is part of life, and that they can handle that. So thoughts are just thoughts. Clients also need to learn that thoughts are okay, worries are okay, they're safe. It's their reaction to these thoughts and these fears that makes their world small and that causes problems for them. They need to know that their safety-seeking behaviors are not actually needed, that they can do this all on their own. So how do we do that? How do we help them learn from this? And how do we set things up so that they're on the right track in treatment? I have 3 formulation questions that you can ask your clients, starting with, what triggers anxiety for you? So I have some different categories there. Most are pretty good at knowing what triggers anxiety, what they try to stay away from, what makes them uncomfortable. So we create a list of those things. And then we want to ask, what does anxiety think will happen if you face that trigger? And I often ask, what's the worst thing that anxiety says is going to happen if we do this? We want to lean into that worst case scenario with them to really get at the heart of their anxiety. Some cannot give you this answer this second question. So a good backup plan is just to say, I wonder if anxiety says, you can't handle this. This is way too hard, something like that. So we'll find a common language around that. And then we want to know, so this is how I talk to kids, I'll say anxiety is so bossy. It has so many rules for people. What are the rules that anxiety tells you to follow? Right? So it's all those safety seeking and avoidance behaviors that anxiety says they should be doing. Maybe that's passive avoidance, reassurance seeking, mentally reviewing, figuring things out. Of course, with OCD, there's compulsions or other rituals, trying to control, suppress thoughts or distract from thoughts, or looking for safety signals, like I need to go to the hospital and make sure I'm okay, or I need to be with mom. So once you have answered these 3 questions, you've got a very tailored roadmap to treatment and everything you need to help your client get the most out of treatment. So we create these situations, and then we kind of have an order to them, which I'll get to next. So way too much in this chart, but here are some examples of case formulation. I'll just go through the first one for social anxiety. So let's say this person, they're very triggered by raising their hand in class. I'll say, what does anxiety think is going to happen if you do that? Well, in this case, maybe it's, I'll go blank. I won't know what to say. I'm going to embarrass myself. I can't handle everyone looking at me and judging me, right? And what does anxiety say you'll do? Well, don't raise your hand. So we want to start to create situations to dig into all 3 of these components. We want to start in our office. So maybe that is taking some, questions from the internet and having them take a risk and raise their hand and answer your questions on the fly in your session. A pretty safe place to practice. Maybe that is then, practicing that with family. Maybe that is next, talking to the teacher and having them plant some questions so your client knows when it's going to happen, when they'll be called on, what the question is, what the answer is. They don't have to worry about being wrong. They just have to practice raising their hand and getting the answer out. Then they could go for it. So there's lots of ways we can help clients to really lean into all 3 of these components. I'm going to make one more point I highlighted there. Test anxiety, because I know that comes up a lot in treatment. Often clients are coming in to meet with me with a long list of safety-seeking behaviors or really formal accommodations on an IPP for how to get through a test, for example. So maybe they have a private space and they pull out, their special pencil and special lavender stick, and they've got all these things set up to make it work for them. Those things make sense, and I want to keep all those things at first because that's meeting my client where they're at. But I think it would be enabling if we didn't have a plan to, in a very graduated way, start to remove those safety-seeking behaviors so that they can see, oh, I wrote that test because I can do that, not because I had all those different measures in place. And I think that's a really important lesson for youth to, excuse me, to learn. Okay, so I want to spend a bit of time thinking about, again, how do we create these scenarios in session? Because often it feels like, well, those triggers are at school or at home or out in the world where I don't have access to. But I think it's just a calling to get creative. So exposure to what we can do in vivo, imaginal, or interoceptive exposure work. In vivo is directly facing the thing that they're fearful of. So some examples there. With separation anxiety, of course, parents are bringing kids into session. We can have a plan with them to work through that anxiety of separating from a parent by having, again, in a planned way, mom sit out in the waiting room for 2 minutes and then come back. And for longer periods of time, maybe to go for a walk around the block. So lots of things we can do there to practice that process with clients. Selective mutism, we want to help them talk to new people and in new situations. So I might meet a client at the library, and I have an example there of a library scavenger hunt where we can practice asking librarians questions. Social anxiety, we can set up lots of social challenges or experiments. Maybe we're walking to a coffee shop together. Maybe within your office, you can support them in working through that anxiety of messaging a friend to hang out or posting something in a group chat to help them learn from all of that work. Test anxiety, lots of ways to bring practice tests in session and do that together, even if it's not the real deal. That will help them be ready for the real test situation. I have a whole ladder example around making mistakes, so I'll leave that for now. Presentations, even if they don't have a presentation currently happening at school, you can create presentations on things that they're interested in talking about or not, but practice doing them with you and family and so on to have that repeated practice and information that they can do this. Imaginal, sometimes it's the thoughts themselves that are the trigger. For example, with generalized anxiety, or they are the fear. So taking some power away from those thoughts and those fears is very possible by simply saying, you know what, I'm going to say that thing on purpose, not try to push it away or block it. I'm just going to say it out loud. I'm going to have my therapist say it back to me. I'm going to write it down and see it for what it is. The more we do that, the more the meaning just kind of drops away from those ideas and those words. So that can be a really powerful process. Draw the feared scenario, write a worry script, like a movie script, and have them walk through actually doing the feared situation. With interoceptive, that is really leaning into all those physical symptoms that they fear and think are too, uncomfortable to tolerate or they're a sign of danger. So there's some ideas there. The internet has lots of ideas, but it makes sense to actually bring those on and work through those symptoms with them. So lots of ways we can do this. A couple more points around how to do this in our office or out, right? Get out of the office, go to the library, go to the coffee shop. But always think ahead to your next session with them. What are we going to be working on next time? Okay, is there anything you need to bring in? Can you bring in that practice test, that presentation, a picture of the neighbor's dog if they're fearful of the neighbor's dog? And use the good old internet. It's filled with videos and practice tests and math sheets, vomit sounds, whatever you need. That is a wonderful resource to all of us. So we start to create these ideas and then we put it into some sort of roadmap for treatment. I often call these bravery ladders or confidence challenges. And it just helps, I think, a bit with buy-in and structure to the whole treatment process so that families can see where things are going and we can make sure they understand the rationale for that before we jump in. So we list those things that we've come up with, some different challenges for facing fears. And often these go from, easiest at the bottom, kind of middle is the medium challenges, and at the top is those really hard challenges. I don't like to get too caught up in having the exact order or having all the steps. I often even just say, is that a small, medium, or a large challenge? Great, stick it on there, accordingly, and not get caught up in ratings because these things change so much. And kids can be really perfectionistic and it can take too much time when it's going to change anyways. So I like to do that and then have some sort of order, but really we're going to mess with that order anyways. I think starting with a really small step at the beginning to make sure kids get on the ladder is important and maybe do that a few times. But in the end, we want to really keep anxiety on its toes and kind of jump all over the ladder as they're willing and ready enough to do that. That is going to help them long term. That is showing them that they are ready for anything, that they didn't do this work in this very, very predictable way throughout, which is not how life will be when they're outside of treatment. Consider the child. Maybe you don't have a full plan. Maybe you have a full plan or, general plan with the parents so that they know where things are going and feel good about that. But with kids, maybe you're just sharing with them what is the next step we're going to be working on so that they don't get caught up in where things are going to go. And last, I just say we want to have everyone's input and make sure that the ladder makes sense and is meaningful. And, parents can see, families can see changes week to week that will be important to them. Okay, here's an example. Sorry, it's so small, of a bravery ladder for facing a fear of making mistakes. So this is just one example, just to show you how we can do this work in our sessions. So first step, again, that's meeting the child where they're at. Maybe that's making a mistake on a coloring sheet, or I like to go on YouTube and we can learn how to draw something together. There's lots of step-by-step instructions. Then we kind of present our drawing to each other at the end and notice all the flaws in that and that we can tolerate that. We can do academic work. So again, go on the internet, print off grade level spelling quizzes or math sheets and just work through that process together. They could practice handing it in to you and being marked and getting feedback or not, depends on what's easier or what's important. Repeat that with subject areas that might be a little more challenging, cause more distress. You could move to sharing mistakes with people who are pretty safe. You could make cards for family members or to friends or teachers and include small mistakes or flaws and just notice that it was less than perfect and that it was okay. We can start to make mistakes where it really counts. Maybe you plan to pass to the wrong person at soccer practice tomorrow or with you out on the field and just ride through that anxiety of it not going, quite right. The end goal here is really just for the child to see that they can do something, they can hand in homework, they can participate in an activity, even when it feels less than perfect. Right, so we're thinking about where do we want them to go in the long run. Okay, so we have all these steps. We want to help kids face their fears. We want to make sure that they're learning as much as possible from that hard work each and every step. So some things to keep in mind. One, again, really the whole goal here is to prove anxiety wrong. Anxiety expects X to happen, this bad thing to happen. So we need to build up evidence through these steps that anxiety does not have it right. That really is the goal. And it's about just gaining all this competing information so that anxiety is kind of discounted. We can do that by tracking their expectations during an exposure task rather than anxiety. So traditionally, we would track anxiety and kind of praise them for seeing anxiety come down. Instead, let's track their expectations. So anxiety says that you won't be able to handle those physical symptoms, Well, let's see. Are you handling it now? Like, do you believe that right now? Yes, maybe. Okay, hopefully that expectation will be lowered throughout your work. After, that's when we really want to ask lots of questions and just consolidate all that was learned from, again, their really hard work during an exposure task. Other ways to really optimize outcomes here. I said it before, I'll say it again here. We want to model the process. So we want to work with families to show them how we create those steps and think through that, to plan those in-session exposure tasks. So you want to be there with the child to create that formula that works, right? To help them work through that anticipation of facing a fear, finding language that resonates with them so they can learn as much as possible from that, and include parents and caregivers in that too when it makes sense. Give parents feedback about how they're supporting their child. That they're going to be really important players between sessions and long after treatment is done. So we want them to feel very confident in supporting their child to keep this work going long term. Combining fear cues. So again, we don't want to work up the ladder one step at a time in a really careful way. When we're ready, we want to jump around and we want to bring in multiple cues. So maybe I'm helping that youth do a presentation in a session, but we're also going to bring on some of those physical symptoms and make it a little bit hard to breathe before presenting, to see that in that worst scenario, they could work through that and still give a presentation. That's really powerful. We want to eliminate safety-seeking behaviors. So here are just some ideas of things that they brought in or told me about in a session. And so we want to account for that. If they're bringing in a stuffy, I will keep in mind, what is the end goal? Well, they don't want to take their stuffy to university or on a job. And so we need to have a plan for, in a graduated way, moving stuffy out of the picture. So let's do that presentation with Bunny right beside you. Okay, next time Bunny's going to sit over there in that chair. Next, we're going to do it again, but Bunny's going to be out in the waiting room, then in mom's purse, then out in the car. And then next week, Bunny is going to stay home and we're going to show you that you can do this even without Bunny. We want to maximize variability, so different stimuli. Let me talk about the importance of different conditions. We all have clients who come in and say, oh, I couldn't do the work this week, the homework task. It was a really hard week. Or I will not be able to do an exposure today. It's been a really tough day. I will say, I'm sorry that it's been a tough day and we should talk about that. But this is perfect, right? We want to show anxiety that you can do this on a good day, a bad day, and everywhere in between. So again, that gets them ready for life long after formal treatment. So a really important relapse prevention strategy kind of built into the process. Okay. Other things to keep in mind, with the PACE, we want this to be client-led as much as possible and for them to own it and feel that they're in charge. But we don't want to get stuck, right? We want to repeat steps, but if they're repeating it for so long and it's so easy, sometimes we do need to take a chance and with permission and collaboration, help them to move along to another step. We want to repeat those same steps again to really build up all that evidence that anxiety does not have it right. So we don't want to be in a rush up the ladder or around the ladder. And practice, practice, practice gets results. We really want to emphasize with families that they need to be doing this work ideally every day and getting a dose of exposure work. Okay, so I've gone through some theory and rationale for this. Now we're going to switch gears a bit and I'll tell you some language that I use with families and some points I want to make for them. Starting with, answering a very common question from parents, how did we get here? So we want to start with psychoeducation about anxiety and help them to answer this question. So I'll often do that by giving them, this behavioral conceptualization, in other words, like an anxiety trap or an anxiety cycle to illustrate how they got here. So, I'll use the specific trigger that I know is true for their child. So your child faces the anxiety trigger. Maybe it's that they have to go to school or they're prompted to talk. And what you're telling me is that your child gets anxious in those situations. and arguably too anxious. And we'll take some time thinking about what anxiety looks like for their child. Maybe they have a stomach ache on Monday morning, or they're hiding behind your leg when someone asks them a question. And I'll say, anxiety tells us to always do one thing, and that is avoid. Don't do the thing that's so uncomfortable. So stay home from school. Don't answer that question. I'll give some examples of this and really highlight, and that makes sense, right? So what happens when a child is uncomfortable and they're avoiding? People jump in to support them. That also makes good sense, right? So they come in and they rescue or have accommodations in place. I will often ask parents at this point to give me some examples of what I might mean by that, and they're really good about doing that. Yeah, I totally answer for her. Or, yeah, I just say, you know what, it's fine. Let's just stay home from school today and we'll reset and try again tomorrow. So I'll have them list that. And then I always have a star there to really highlight this is not about blame or shame. It makes good sense that you're doing these things. And it makes sense because everyone feels better when we do these things. The problem is that everyone is also reinforced. Your child has learned, if I just wait long enough, they'll answer for me. Or if I just drag my heels long enough, I'll get to stay home from school. And so next time they're inevitably faced with that trigger, anxiety is going to go up faster, it's going to get bigger, and they're more likely to avoid. So I want to give them some hope here. The point of this is that treatment is really about just shaking up this cycle and making sure that you know what to do instead, not just take all of this away, but know what to do instead. So, give them a brief overview, like we are going to create very planned opportunities to practice bravery. So we're going to create a bit of a bravery map. I'll show them a ladder. That is so we know where things are going and there's no surprises, right? I really want to make sure they understand the rationale for this before we jump in. Before we do that, we're going to create a reward plan. So we want to celebrate your child doing hard things and seeing that they can do this, that came out the other side. I don't have time to get into reward systems today, but that is a really important piece. And then when we have that overall plan, we'll get into the nitty-gritty details. We'll set very clear and specific goals so you know what to do instead, your child knows what to do instead, and everyone's set up for success. We'll take this one step at a time. Our whole goal here is to meet your child where they're at, right? Make sure we're setting them up for success so that success can breed success. And we're going to repeat steps so we can all see that things get easier with practice. I'm not emphasizing habituation, but I do want them to have a bit of hope that things will get easier, that they all can do this. Okay, so some language that I use before and during and after exposure work. Setting things up with the child, I want them to really start with externalizing anxiety, considering a name or drawing it or model of it to really represent their worries. So we all know who we're up against, right? We're all going to team up together and be working against anxiety. Some just like to call it anxiety, and so that's the example I'm going to use in this presentation. And so some language I'll use with kids, we're going to say, bring it on to anxiety. We're going to face anxiety head on, take that control back. We're going to break anxiety's rules. I'll say, like, that's the really fun thing, is this is the one place where you can break the rules. We're going to stand up to that anxiety bully. We'll often talk about anxiety as being like a bully, and so we need to stand up to it. We're going to do it one step at a time. We'll do it together, and then you'll know what to do to keep practicing this before I see you again, right? I emphasize that with kids as well. Really, my underlying message here is, well, transparently, I do say, there's no surprises. I'm always going to tell you what's coming next. In other words, you can trust me and my intentions as I ask you to do hard things. And with all that, we really want to take our time to build that trust and rapport before we jump into this. My message to caregivers about doing exposure work, I need them to know that they also need to help us, be on our team and be supporting their child rather than accidentally supporting anxiety. And I need them to do that with confidence and modeling confidence, because their child is going to look to them to see, is this okay? Right? So we want to help parents know with their tone and their eye contact and their body language and their words that they are sending a message, you've got this and I've got you. So again, to both, we want to highlight we're doing this together and you got to keep going before I see you again. Okay, some other language before jumping in. I focus less on how anxious will you be if we do this, and which is usually, it's going to be really high. I don't know if I can do it. So I tend to say, how willing are you to take this next step? That usually gets things off the ground. We want to think about body language as well, not be approaching something, like, I cannot do it, but I'll help them get their game face on and I'll put mine on too, and we tack anxiety together. Focus a lot on bravery and how brave they are and how, with little kids, like you have such brave muscles in your body, rather than how anxious are you, and getting stuck there. And I'll try out other language as needed. It might be, if we were to do that, how big would that urge be to book it out of there or to pull out your phone and look at your phone, or if it's OCD, to engage in a ritual? Sometimes anxiety is not the word for them. They say, well, I just get angry or I'm upset. And that's where I'll start and make sure that our language makes sense. Okay. During an exposure, this is where we really want to help them lean in and fully experience the thoughts, the feelings, and all those physical sensations that come up. Help them understand how it feels in their body, ask them to describe what it's like, help them see that, yep, it's uncomfortable, but here we are, you're doing it. Get into those thoughts. What is anxiety saying to you right now? Then we can, bite back, boss it back. And just again, to highlight, our language here is not around tracking anxiety and praising them for lowered anxiety ratings, or, talking about how wonderful it is that their anxiety is coming down, right? So a very different approach than maybe what we're used to. Definitely different than how I was trained. After, so where we bring it all together and learn as much as possible from that. So, wow, you weren't sure you could do that, but you did. What does this say about anxiety? Anxiety said this was going to happen. Did it? Awesome. Okay, so anxiety is a liar, or we can't trust anxiety. What does this say about you? Wow, it says that you can handle all those feelings, that you can do what you want to do. Anxiety doesn't get to decide that for you. Okay, language is just so important. So I had to put one more slide in. In all of this, find language that works for you, that feels authentic and genuine and will come across as such. With teens, we want to be particularly cautious in all of our praise and curious questions, and essentially play it cool, right? They're easily spooked. So I might say like, nice, I saw that was hard and you did it, right? Or something more subtle like that. When I'm creating exposure tasks for them or with them, especially with home exposure tasks, I'll incorporate a lot of motivational interviewing type questions or language. So we'll set a goal and then I'll ask, how important is this to you right now? How willing are you to do that this week? How confident are you that you can do this? And that'll give us a lot of information. If confidence is low, we need to pause there and find some ways to build their confidence before sending them home with that. Maybe it needs to be a smaller goal, or we need to look at all the evidence that says they can do this. And I'll want to ask about other potential barriers to getting this work done. Maybe they have soccer practice 6 days this week, and we need to revisit our goals and be realistic so that they're set up for success. Okay. We want to always pause and appreciate that we're asking kids and families to do hard things and be uncomfortable. So how do we make sure that we can do that? Because we cannot drag a child or a teen through exposure work. Well, we want to take that time to build rapport and trust. We want to understand what is important to them, what they value, so we're working in line with that. And there's kind of a point to what we're asking them to do. We want to be transparent about what we're trying to accomplish and make sure that they know what's coming next. Give them agency whenever possible. Give them some choices about what we'll do next so they can own it and appreciate it. Don't wait to incorporate rewards. Have that as part of your plan and make sure it's an effective reward plan, which essentially means make sure the goal is something they can actually achieve, it's within reach, and that the reward speaks their language. It's actually incentivizing. And keep it fun. I want to go through all this, but I'm afraid I'm running out of time, so I'm going to keep moving along, but keep it fun and get creative. I think also an important part of this process is to track progress, like any kind of treatment, but just stop to celebrate those successes with families. Keep that ladder updated so they can see all that they've accomplished and maybe that next step where they need to go. Make sure everyone can see changes and they're saying that there's changes. And if not, don't be afraid to tweak the plan and try something different and not get stuck doing the same, failed exposure task again and again, or week after week, they're coming back and not doing the work. You got to change the plan. Okay. Some common problems that come up and hopefully some solutions to those things. Um, Students always ask me, what I thought we were doing this really hard thing, but they didn't seem to be experiencing anxiety, and I don't know why. Well, some things we might think through. Maybe the thing we're asking the youth to do is so different than what they're actually facing in real life, what the actual anxiety triggers are. So, for example, maybe we're going to the mall for some social anxiety exposures, but our appointment is on Tuesday morning, and we go to the mall, and the mall is filled with people who can be at the mall on a Tuesday morning. What they were actually talking about is going to the mall on a Friday afternoon where all their peers gather after school. Very different. So maybe it's too dissimilar, and that's why we're not seeing anxiety. Maybe they're using you or a parent as a safety signal. Um, Maybe we're accidentally providing them reassurance, like you're okay, right? It can happen really quick and really easily. Or we're talking too much or distracting them. So they're actually leaning out of the exposure process, and we need to help them lean in. Um, I won't go through all this, but often being too perfectionistic and getting everything just right and making sure they have all the conditions is an avoidance strategy and a way to not lean in when they're doing it. White knuckling it is doing it, but really with their whole body sending a message that this is still intolerable. Right? So we really want to get curious about all these and then problem solve with them. Kind of on the flip side, what if they just rate everything a 10 out of 10 and they say it's too hard to get started? Well, again, we can't drag them through exposure work. So stop, name that, get curious about that. Maybe it's that the goals are not actually meaningful to them. Maybe it's that they haven't realized yet that the anticipatory anxiety is usually way harder than actually going through this step. So maybe it's helping them just get started and see, and say we can always stop and go back to the drawing board if it really was too hard. Let them know we can always find a smaller step, play around with these variables. Who is there? What are we asking them to do? Where, when, scale things back and meet them where they're at any point. Go slow, just focus on the next step. And maybe you pause and you help them find evidence and you get curious and praise them for things that they have done in the past that were really hard, that did bring up anxiety, but that they were successful with. So you want to focus a lot on past bravery and understand how that information can be applied to this situation. And always get back to basics. Increase the reward if you need to. Make sure there's that rapport and that trust there before you get back into it. Okay. No client has come in and said, I cannot wait to do hard things today and feel uncomfortable on purpose. So we want to watch for avoidance that can really take over our session, right? So there's kind of 3 categories I created here. One is that client who, thinks for a long time, there's long pauses, and then you never have time to get to that exposure task. Um, I'll come back to some solutions to that. Kind of related to that, there's the person who comes in and there's not long pauses. They just talk and talk about every detail of their week, about things that are not super relevant. And before you know it, again, the session is gone. You haven't done exposure work. With either of those, I think it's naming it and making sure that they still feel heard and have that rapport with you. So maybe you say, there's a lot of important things you need to talk about, and that's good. I'm glad you feel you can do that here. So that neither of us lose track of time. Why don't we set a timer? We'll have the first X minutes to talk about your week and understand it, or to be making that plan. And then when the timer goes off, it's the timer telling us we've got to switch gears here, right? So then you're not feeling bad interrupting and saying, okay, we got to move things along. There's that person who comes in and they have big existential questions or a crisis of the week or 10 crises of the week. Again, we need to hear what's going on for our clients. That's important. We might need to spend some time problem solving around that and helping them to learn from things that popped up. But again, it can lead to missed exposure work. If there are true crises, like your client is self-harming and really not able to tolerate distress at all, then you might need to pause on this treatment right now. They might not be in a place to learn from exposure work. And we need to make sure that they are safe and stable before we do this. So again, I would name that that's not the right treatment for us right now. Let's switch gears. Here's what we're going to be doing first so that they're not under the illusion of exposure work treatment and lose trust in that process, right? If they feel like they've been doing that the whole time and it's not working, it'll be harder to switch gears and do that when it does make sense. In all of this, I mean, we want to normalize that exposures are hard and really acknowledge what we're asking them to do. So again, we want to align with them. Okay, I wanted to make sure we got to this slide. We have our own barriers as therapists to doing this work. I found this very interesting. Although research is showing that exposure work is actually the key ingredient to CBT treatment for anxiety, only 10 to 30% of clinicians endorse incorporating it into routine care. In fact, it's actually one of the least used evidence-based practices in clinical care. What are they doing instead? In research, they're reporting that they opt for adopting relaxation strategies, right? That earlier component of CBT interventions, even though it's not supported in anxiety work and might even be contraindicated. Top 3 reasons cited for not doing this then. One is that there's a lot of things going on, right? There's comorbidities. To that, I would say, I mean, good assessment is important for good treatment again. So we can't tackle everything at once. We want to be clear on the whole picture and then prioritize accordingly. Get to the exposure work when it makes sense. Another top-cited reason is that it doesn't feel good to ask someone to be anxious. And it does feel strange at first. I think we need to remember that this is something we're doing for our clients, not to our clients, and that it is safe and it is effective. There's also, citations around concerns that a client will drop out if we're asking them to do this. So again, I think that speaks to really the importance of making sure at the beginning that everyone understands the rationale. Don't be afraid to sound like a broken record and make sure everyone's on board and consenting to this before you jump in. Especially with OCD work where you might be asking them to do some fairly strange things. So hopefully I've made a case for doing this work, that it's the most supported way to get desired results for our clients. So good news for our clients. And the good news for us, we don't need to spend our careers repeatedly working through a CBT manual, right? We can get creative. We can support really tailored exposure plans for each client that we work with. Okay. So I guess we'll go to Q&A.
Yes, thank you, Dr. Bliss. That was great. Yeah, so attendees, if you'd like to pose your questions, I can see one's already there. If you could, I'm sure you can see them, Dr. Bliss.
Yeah, so the first question, would the same strategies work well with adults? Exposure work is highly effective for kids, teens, and adults. So yes, it is the #1 treatment for an evidence-based treatment for anxiety work across the lifespan. I'm just going to take this poll down. Your language would probably be different, and what you're asking them to do would be different, right? They're not in school. They might not want to boss back anxiety. You might have different language, but it is the same aim, the same rationale behind it. Yeah. Maybe I'll also stop sharing so I can see people. There we go. Okay. Thank you. Would you still use a SUD at the onset, within, and at the end of the exposure, or are you moving away from that? Yeah, I will sometimes use anxiety ratings to help create that ladder and just know, where things should go or how they feel to that client. But I don't want to spend too much time doing that, or really talk at length about how anxious they would be if they were to do these things. That's why I often go to, is that a small, a medium, or a hard challenge? Um, and then during the exposure, that's when it's really important to get away from those ratings and focus more on those expectations being violated, right? Like proving again and again that anxiety is wrong, and that they start to build this belief that they can do this, rather than, oh, your anxiety is going down. That's amazing. We need to control and see anxiety go down. So yes, we do move away from that in this latest model. I mean, when we're leaning into exposures, still talk about anxiety itself. Um, how does that feel in your body? Might, go through some of the common physical symptoms. I wonder if your heart is beating fast, like it does for many people I work with, or if you're feeling sweaty or shaky or dizzy, right? So we'll talk about anxiety in that way and make sure we're fully embracing that experience. It's not that I'm afraid to use the word anxiety. We just don't want to focus on anxiety being reduced or controlled. Yeah, so I mean, lots of people are doing relaxation and exposure work at the same time, and that's how I was trained too, for sure. Um, there, uh, anyway, relaxing can work with exposure therapy. I knew this question would come up. I still think that there's room for distress tolerance skills and being able to, relax your body and know that, for example, it could really help before a presentation to pause and do 3 deep breaths, or something like that. Know how anxiety feels in your body, and and things you can do to manage that. It's just not during the exposure work. That's where we want to just fully lean in and see that they can handle that. So I think there's room. It's just on, maybe on either end. Or again, maybe some clients need to have some distress tolerance skills before you can ask them to challenge themselves in such a big way. Would there be any treatment guides integrates exposure therapy applications? Any treatment guides? Like manuals? Is that what you mean? Yeah. That's a good question. It's funny, like, I work in the OCD clinic, and we do a manualized group treatment for OCD work. Um, But the group work is really learning information about OCD and strategies, like to boss back OCD, for example. But then we break off and we do that really individualized work. And it's such an individualized, tailored approach that it's kind of on the fly. It's working through those formulation questions, and creating a language with the client to work through it. I'm trying to think of a specific anxiety manual. And I'm not sure, to be honest. I can think about that, and can see if it can be posted with the slides, if I can come up with something. Okay, I'm losing track of the questions here. Sorry. Or can I read more of your work? Where do you suggest I do further training on this? Oh, further training. I mean, I don't know a specific place, but I'm sure there are many therapists like myself who love working with others, and love running group work where we can talk through these things with, kind of a hybrid group and individual treatment model. So we can all talk about these things together and then go and have this very tailored approach when we break out during a group. So I'd reach out to other therapists. You can reach out to me if you want some of this experience. I think that's the best way to learn, is by doing it with others, rather than reading a bunch of books, but maybe that's just me. Oh, thank you for these really kind words. I'm wondering if anxiety, GAD can be so severe that it presents similar to OCD. Come OCD present in certain. Yeah, yes, and yes. I think that is the number one thing to tease apart is what is GAD and is OCD. I think Dr. Arnold answered this a bit last week. With OCD, we see those themes coming up again and again, really specific themes. And often with OCD, there's more than one area. Like I'm worried about someone being harmed, and I'm worried about things being just right, and I'm worried about things being perfectionistic. And with GAD, the themes tend to be really everyday worries, like how am I going to do on that test? Does my family have enough money? Are we all getting along? So there's a different kind of flavor to the worries themselves. And with OCD, you see some clear rituals or specific ways they're working through those thoughts. With GAD, it's more just rumination and mentally reviewing things. And is it common for OCD to present in certain environments? Yes. Lots of kids, for example, they present just fine at school, which might be a contaminated place. That is not the problem. It's when they get home that they need to keep it clean and safe and keep those school germs out. And maybe that's where all the issues are. So all the more reason to ask those formulation questions so you can make sense of why they're doing what they're doing or why they're staying away from things that they're staying away from. Yeah. Yes, exposure therapy is also the first line treatment for OCD, but it's exposure and response prevention. So it's understanding those triggers, it's understanding the worst thing that OCD would say will happen and leaning into that. And then it's having a very clear plan before you jump into the exposure work on how you're going to mess with OCD, how you're going to mess with those rituals or compulsions in some way. But same idea, just adding the compulsions into the formulation. If a parent has similar fears to their kiddo, yeah, such a good question. All the more reason to bring parents in and understand where they're coming from and making sure that they are confident supporting their child in doing this and showing their child that they can do it, right? If parent has OCD or anxiety, they might need to have more time with you and maybe their own individual work so they truly can present in a way that's going to support their child. So important to spend time with them and understand where they're coming from for sure. It's a very good point.